Okay, so today we are diving into a topic that has been debated and misunderstood and sometimes downright confusing. Hormone replacement therapy. I should have added intimidating to that too, because I sure didn't know where to start. But should we take it? Should we avoid it? And how do we know what's best for our own bodies? So we are beyond thrilled to be joined by Dr. Sandy Rice, who is a physician with over 35 years of experience caring for menopausal women and the author of the book, The Estrogen Question. And for anybody that hasn't bought that, buy it immediately because it's a comprehensive guide to hormone replacement therapy, exploring the benefits, the risks, cutting edge research on how estrogen affects everything from chronic disease risk to mental health. And Dr. Rice, we're going to call her Sandy, is here to arm us with the knowledge we need to advocate for ourselves and to make informed decisions about our health. So Dr. Rice, we are so happy to welcome you to Lady Party and help you kind of demystify HRT with your invaluable expertise.
Yes, thank you for being here. I'm so excited.
Thank you. I'm thrilled to be here because this is obviously a subject that I'm really passionate about.
Yeah.
Well, so where should we start?
Well, yeah. I think it's always cool to kind of start with a personal story. And so I'm going to raise my hand and just give like a 12-second overview on how I got to know Dr. Sandy Rice. So I have had this kind of tumultuous relationship with my reproductive system my whole life, from like heavy periods and then kind of the more pivotal things I think are around like trying to get pregnant and not being able to, and many miscarriages. And so my uterus and I know my reproductive system is more than my uterus, but like we have been at odds for a long time. And so a few years ago, I had a doctor who said like, well, what about a hysterectomy? And I was like, oh, what about a hysterectomy? And so I ended up, my mother-in-law gave me Dr. Sandy Rice's book. And because I was like, well, if I don't have a uterus, does that mean I have to be on hormones? And I had this lovely consultation with Sandy, Dr. Sandy. And I was like, oh, okay, I am going to get a hysterectomy. And then I know like what I want to do in terms of HRT after the fact. And I just think like for years, and my hesitation was because I grew up with a mom who was like, oh, hormone replacement therapy, it'll give you breast cancer. And she actually was on HRT and had ended up having a lumpectomy. And we always assumed that's what had happened. So but come to realize after reading Dr. Sandy's book, like, no, that is not it anymore. And so for years, there's been like the advice around HRT has been all over the place. And so maybe let's start there in terms of why has the conversation been so controversial? And I know you'll reference the study, quote unquote, the study that everybody talks about. And what does the latest research tell us?
That's a great question. I mean, this whole controversy is, I think most women are struggling with it. And I think a lot of it in the background, there's this whole issue about menopause being, is it a natural thing? Is it a natural process? If it's a natural process, why are we treating it? And so that's kind of been in the background with a lot of this discussion that we've had. But the truth of the matter is that when women go through menopause, I mean, they're distressed. There's a lot of distressing symptoms that affects their quality of life. And as we'll be talking about, going for years without estrogen, women are living a third to half of their lives beyond menopause now. Going that long without estrogens can lead to some negative health effects. So the big controversy has been, does hormone replacement therapy, HRT, cause more benefits or more risks? So that's where the pendulum has been swinging back and forth and back and forth. So let's start, I'll try to make this as succinct as I can. Hormone therapy became available for commercial use, for use for women back in the 1950s, 1960s. And it was like a miracle drug back then. Women were suffering their quality of life, the vaginal symptoms, just everything. They were really welcoming, having hormones. And as more and more women were on it, scientists were looking at what it was doing to them. Yes, there seemed to be a slight increased risk in breast cancer in women who were on them, but other health benefits were becoming evident. There's quite a few studies then that were looking at various aspects of women's health, and one big one was bone health. Back then, in the 50s and 60s, women were dying within weeks of having a hip fracture. With the medical technology we had back then, we couldn't care for them, and women were being crippled with back fractures. They were bending over. The Dowager's hump that you've probably seen pictures of. So women who took hormones were being spared by all that. Plus, there were studies that seemed to indicate that it helped their risks of dementia. There was a lot of information in that regard as well. But the big thing was the heart. It was apparent that women who were on hormones had less heart attacks, heart disease. And there's a big study called the Nurses Study, involved over 40,000 women in the 70s and 80s, that showed that women who took hormone had a 50% decreased risk of getting a heart attack. So that was, that's big, because more women die of heart disease than all breast cancers combined. Not just breast cancer, but all. And that's the way it is today. Your number one killer is heart disease. So back in the 1990s, the National Institute of Health said, hey, we need to get a big study going to prove once and for all that hormone therapy is good, because there was still a little controversy about it. And so they launched this study called the Women's Health Initiative Study. It was huge. It cost millions of dollars. It was run by menopause experts across the U.S., involved over 30,000 women. And it was the gold standard kind of study, which is you put half the women on hormones, half the women on a sugar pill or a placebo. And then you follow them along, and, it's carefully matched. So the conclusions of this study were going to be the bottom line. But what happened was the study was terminated early. It was supposed to go on like 8 years, and they stopped it at 5.5, because it looked like there was more risks than benefits. And the study was released kind of to the news before we doctors even got to see it. And it was like, hormone therapy causes 26% increase in heart disease, 26% increase in breast cancer, doubles your risk of blood clots, increases dementia. This was a huge news story. It was sensationalist. It was shocking. So really, long story short, is it just kind of ruined the reputation of hormones right there and then. Millions of women went off their hormones. Doctors, were like, oh my gosh. And new guidelines came out. Don't use them. Don't use them unless you really have to. So this study came out in 2002. And for the next 10 to 15 years, surprisingly, nothing changed. That's just the way it was. The guidelines were don't use it. There were more risks than benefits. And doctors, even in OBGYN, received very little training on hormones. In fact, received little training on menopause. So there's this dead space here for the last 20 years, practically, on treating women. So the thing is, in the last 10 to 15 years, slowly but surely, data has been coming out about, okay, what's up with the WHI? Why? What happened? Well, a lot of stuff has come out, and a lot of people don't realize this, is that, but very quickly, number one, the results were totally over-exaggerated. It was like one extra case of breast cancer or one extra heart attack occurred per 1,000 women. That's considered very rare, okay, for women who took hormones. Second thing is that the average age of the women in the study was 63. There's a lot of women who were like 70, even up to 79 in that study when they were put on the hormones. And what we know now is that if you go 10, 15, 20 years without hormones and then go on them, they're not going to do the good things that we believe they do. In fact, they could maybe cause some negative things, which was probably part of the problem.
Came out in the study.
Yeah, but the third thing, I'm not done yet. The third thing is that the hormones they used were the hormones that were used at the time. And one was, they were not bioidentical hormones. They were not the same hormones our body makes. Premarin is a kind of a mixture of hormones that comes from horses. And then the progesterone, you need to take two hormones, which we can talk about, was not natural progesterone. It was a progestin, a synthetic drug, which we now know is toxic to the breasts and toxic to the blood vessels. So all of that combined likely is what caused that slight increased risk of problems in the study group. So the problem is that we now, we've looked at the WHI closely. We've had a number of other studies. Unfortunately, nothing as big and as powerful as the WHI, but many cumulative other studies now that we can conclusively say that, bioidentical hormones, what our body makes, given to women who are going through the menopause transition will cause more benefits than risks. And the problem is that this message just isn't getting across to either women or their providers.
Right. So I'll give you like my little story. I recently, like about 6 months ago, went to my OBGYN and she had mentioned HRT. And I kind of was looking at her like, what are you talking about? Like, why, like, really get on birth control? And I was like, well, that can fix a lot of problems. I mean, that could tick a lot of boxes, getting on birth control and then also, having those extra hormones. But I was just in kind of disbelief and just kind of was questioning her. But she said that all these, she was talking about studies and that, there just hadn't been a lot of investment in women's health, like figuring out who we are and what happens in our bodies. Hence probably the reason why they stopped that study 3 years prior or something. They were just like done with it. She got me thinking. And then, so I'm going to go back and talk with her, but she was talking about, it'll help you with the flat butt. They call it flat butt, where the estrogen just starts to kind of leave. And then you just kind of, your body starts losing that elasticity and just those hormones that create, I don't know, I don't want to say like voluptuous, body, but yeah. So I just was in shock because I hadn't even really heard about it until she mentioned it to me. So I feel like there's just so many like the myths and then also just not enough research being done and the providers aren't getting that information or they're not, I don't know, getting trained in it or it's not getting past the desk.
Yeah. And I think one of the things that when we were researching this episode and I was talking to Dr. Sandy, she was saying that only 7% of women are now on HRT because of kind of the propaganda around that study that was done that was, like, as she said, totally sensationalized. And so people hear those sound bites and that stays in their head because I know when I was looking for a doctor that would be pro HRT, even Dr. Sandy was like, we got to be a little careful. Like not everybody believes in it.
Right.
So the fact that you have one that is even recommending it to you now that you're kind of, prime perimenopausal is probably, you got a good one there.
Yeah. Yeah. I mean, and she did prescribe something, but apparently my blood pressure was too high for this specific birth control or something. So I don't know. I have to go back to her and get a little bit more information. And then talking with you is amazing. And then I'm going to read your book and then be more informed because we need to be informed as women too, especially with our bodies and everything that's going on. So what are the risks? What are the risks of not having hormones in your body? And do they completely go away, the hormones, or do you still have a tiny little bit after menopause and then it, decreases, or like what's the graph there?
Yeah, we can kind of go into, the whole stages. Perimenopause, if you think that we can talk about that, but it's a little, I'm a little confused about the stages. So perimenopause is those 3 to 5 to even 10 years before menopause. That's when the hormones start going down. And we can talk about that more. Menopause is when the hormones kind of bottom out. That's when your ovaries no longer make estrogen or progesterone. Your fat cells do make some estrogen. So what happens is you still have some estrogen in your body, but it's like a tenth of what it was before. So it's very, very, very low. So that's postmenopause.
Okay.
That
Yeah.
sense.
Yeah. Interesting. Yeah, I didn't know if it went away completely or if you still had just a tiny bit. So what's the health benefits of having more?
Yeah. So when we're prior to menopause, our estrogen levels are very, very high. And we know that estrogen does more than just deal with our reproductive systems. I think a lot of people think, well, it's important for breast development and ovaries and uterus and menstruation and pregnancy, and they think that's kind of it. Well, you can't live without estrogen. You absolutely cannot live without estrogen, and men can't either. Estrogen is very important in both the male and the female body. And I could just go down each system, but let me backtrack a little bit. So what happens is at the time of menopause, when your estrogen level does go down. Now, if you die, no problem, right? You're gone. Well, that's not very nice. In the 1900s, the average life expectancy was 50. Okay, so prior, up until about 1900, women really weren't living much past menopause. The average life is so. That's part of the reason we're kind of a little in the dark about what to do, because, it's really been a relatively new issue of women living 20, 30 years without hormones. So what you're asking is, okay, what is it bad to live the half of your life without hormones? Yes, it is really bad, because what do hormones do? Well, number one, they're really important for your bones. Your bones are always being broken up, building down. Estrogen keeps the breakdown process in check. So when you lose your estrogens, your bones start going thinner and thinner and thinner and thinner and thinner. And so if you don't take estrogens, your bones are going to get thinner faster than if you took estrogen. So that's number one. So estrogens definitely help prevent osteoporosis and help prevent fractures. Number two is your brain. Estrogen actually is what they call a neurohormone. Your brain needs estrogen. Estrogen helps the brain cells get their fuel, which is glucose. They help make those neurotransmitters, which are like acetylcholine and serotonin and dopamine. They help the brain cells actually connect and talk with each other. They help inflammation. Estrogens really play a huge role in your brain. And that's why when women go through perimenopause, they can go through all sorts of issues. They have this, this brain fog. They have mood swings. That's because your brain cells are kind of like, ooh, but they're not functioning as well without the estrogens. Just to diverge a little bit, there's some wonderful research about that. It's possible that lack of estrogens when we go through the menopause transition may be what's actually going to be the reason why women get more Alzheimer's than men down the line. That took its toll on our brain when we went through menopause. There's a lot of controversy there, but there's some really interesting research that estrogens actually can help our brains from aging too quickly. So that's another big area where we need more research. Number three, your blood vessels. Men have higher risks of heart disease than women until we go through menopause. When we go through menopause, boom, our risk of a heart attack goes up to equal of a man. And the question is, why? Well, it's because estrogen has kept our blood vessels healthier throughout our lives until we lose them. When we go through menopause, our cholesterol goes up, our blood pressure tends to go up, our blood sugar tends to go up a little bit. All those things increase the chance of you getting plaque on your arteries. And when you get plaque, that plaque can build up and then it can block and then cause a heart attack. So we know that women who take estrogen, the research is really quite robust. The women who take estrogen have less of a chance of a heart attack than men, because it just keeps our blood vessels healthier. So those are okay. One more. You were talking, Megan, about the flat butt and the body fat and everything. Estrogen has a big role in where our body fat gets deposited. So as young girls, we have these kind of beanpole shapes, and then when we go through puberty, our estrogen level starts to increase, and that puts fat on our breasts, on our hips, and our butts. And estrogen keeps the fat from going onto our middle, around our abdomens. So when we go through menopause and when the estrogen level goes down, then the estrogen isn't there to stop the fat from going around our middle. So you get this belly fat. So women who are going through perimenopause, they're kind of like, what is happening down there? And I'm not eating more, I'm not doing anything, but it's because the estrogen isn't there to stop the belly fat. So the fat kind of starts diminishing from the butt and the arm. So you kind of lose that, and then you get it around the middle. The thing is that it's not just a cosmetic thing. This fat is also inside. If you look at an X-ray or MRI of a woman who has kind of this more muffin handle sort of thing, there's fat inside, and that inside fat is called visceral fat. And it's around the organs. It's even in the organs, like in the liver, and it's even around the heart. And we know that people, even if you have two people the same weight, whoever has the most visceral fat has much poorer health. It increases heart disease, increases cancer, it causes inflammations, and it increases diabetes. So when women go through menopause, they have an increased risk of diabetes. And diabetes, another one of those chronic diseases that can cause so much problems. Women who take estrogens have less diabetes. But here's what kills me is that even in the WHI, the women who took estrogen, they showed that they had less diabetes. You didn't even hear that when the study came out, and that's huge. So the long story is that estrogen's a whole bunch of stuff that is very beneficial for many of the diseases that really limit our future lives. Now, the big thing you probably are saying, well, what about breast cancer? What about breast cancer? Well, that's the bugaboo because, all you have to do is say breast cancer when people just, oh, I'm not going to listen to it. I care about heart. I don't care about diabetes. I don't care about my bones. I just don't want breast cancer. Well, there's no evidence that estrogens cause breast cancer. There's just absolutely no evidence that they cause. Now, the breasts are dependent on estrogen, so if you have breast cancer, if you've gotten breast cancer and you take estrogen, then yes, that may make that cancer grow faster. But you know what? All the long-term studies aren't showing that you have a higher risk of dying from it. So it's kind of like, well, if you have breast cancer and you take estrogen, it makes it grow, well, it might get diagnosed faster and treated faster. So the breast cancer issue is definitely a concern. But I have to say is that you have to look, that's why you have to look at the whole benefit risk thing. Diabetes, osteoporosis, heart disease, and even maybe dementia. Those are just as or more scary cumulatively than breast cancer. So that's why there still is some controversy, because there are some people, who they just can't get their hands around anything that might slightly increase the risk of cancer.
Incredible. And I think, people that know me too, I've been on the Dr. Sandy Rice train for since we started talking about it, because it's people, just my own, again, personal experience, so I started seeing some fluctuations in my period. There's kind of three things that happen, and I never put them all together as oh, this is probably perimenopause. So I started having these some were heavy, some were really light. And I was just oh, I'm probably phasing out, and I was ecstatic. So I was that happened. But then this other thing happened when you talk about kind of the mental shifts and it happened right around age 40, where I was I stopped being able to handle stress like I had always been able to. I've always been someone that can take on a lot of stuff. And all of a sudden, little things were my anxiety was so high. So I was I started thinking to myself, do I need to go on some kind of anti-anxiety medicine? Because it was becoming unmanageable for me to breathing exercise and meditate through kind of thing. And so I was whoa, but I never would have correlated that with that, oh, and my period's light. And so this might be, I never would have that to me, that neither one of those, well, periods may be hormones, but not the mental health stuff hormones. And so, and I think what you said is some women can start this transition, perimenopause into menopause, up to 10 years before their actual last period, which puts women in their some in their late 30s, mid to late 30s, when they start this transition, which in today's world, some people are even trying to get pregnant, at that time. So it's this weird, women, we don't know that this miracle estrogen that powers, we don't know it powers basically all of our systems. And what you said to me, which I was, because then at the same, that third symptom I was having is I was starting to gain weight in my belly. And I'm what is going on? I've never eaten better. I've never exercised more. What is happening to me? Yeah. And what you kind of gave me permission, and probably hopefully some of our listeners permission too, would be yes, of course it's cosmetic, that you're no, I still want a flat stomach. But it's what that weight gain means in terms of your cardiovascular health, that pay attention to this. This is not just a vanity thing. This is something we're living longer, and a third of our lives can be spent in this period. And so the faster, and I think the other thing you said that I think is really important is you can get on these too late and they won't have the effects. So it's in terms of how do you build that relationship early on with somebody that a trusted medical professional who knows about HRT and the effects it'll have on your bodies, to make sure that you're not going through it. But that was a long-winded way of saying because the other thing I don't think people know about is the fluctuation between estrogen and progesterone, in terms of, we should know all this stuff. We all have periods, but how do those two work together? And the fact that I now don't have a uterus, I actually don't need progesterone.
Yeah. Just to kind of just add to what you were saying about younger women, is that, the statistics is the average age of menopause is 52, and 90% go through menopause between age of 45 and 55, but 4% go through menopause between ages 40 and 45, but 1% of women go through menopause before age 40. So then if you're working backwards, like you say, there's people, in their 30s that are in perimenopause. Another statistic that always impresses me is that, 6,000 women are going through menopause every day in the United States. 6,000. So if you do the math, 1% out of 6,000, there's a lot of women going, through very early menopause and having all those symptoms. And they go to their doctors, and the doctors just kind of shrug their shoulders and, say, well, here's an antidepressant, or here's that I go exercise more. And, they don't really get the counseling, that they need.
Yeah.
Yeah.
I feel like we don't have any information. We just have not been told, and there hasn't been enough research or enough people researching it to get it, like, to blanket certain areas and offices to where they're like, yes, you're a woman, you have estrogen and progesterone, and when you go through menopause, it goes away. So therefore, you're missing something that you've had your whole life pretty much. And then you just chalk it up as like, oh my gosh, I'm crazy. My brain, I'm getting, or my stomach, I'm getting old. My metabolism's gone, because nobody has told us ever. I mean, I barely got even told how to use a tampon and a pad. So let's just go there first. Like, oh my gosh. So I don't know why it's taboo. I mean, when we talk with your friends, it's never taboo, but we don't know all this information, which is just, it's making me sad now, because I feel like I've been through this mental thing thinking I'm like crazy. Like, I think I'm going crazy, but yeah.
Yeah, I mean, there's some just fascinating books on the history of menopause, and I mean, women were institutionalized. I mean, when they went through the transition, I mean, in the past, they were just regarded as, they're crazy. What they didn't understand any of this, but they knew that there's something was happening, and it was pretty scary. Women were treated really poorly during,
Sounds
I mean, they were basically, well, you're done having kids and you're crazy, out the door. I mean, we're
done
just
with
been,
you.
yeah, well, that's the way that's where we're coming from.
Yeah, well, you could send me to Bali. I'll go there. That's fine.
It depends on what the institution is.
Yeah, exactly.
But explain the progesterone, because when typical HRT is both, right? And so what is progesterone doing for your body?
Yeah, that's a great question, because so when back when they were trying to figure out, what the best HRT was back in the 60s and 70s, they just started with plain estrogen. And then they found that women were having bleeding problems, and it was really causing problems. And then they kind of figured out, when they were able to start measuring hormones, that in the typical period, you get the estrogens the first half of the period, they ovulate, and then you get the progesterones, and then the progesterones, change the uterus and then create the period. So what we know now is that if you just keep giving estrogens to people, then it keeps building up, building up, building up, building up, building up, and then that can cause a lot of bleeding problems. But that continued buildup also can promote the chance of uterine cancer. So we now know, or we've known for quite a while, that if you have a uterus, you really need to take both, because if you just take the estrogen, not only will it cause more bleeding issues, but there is a slight increased risk of uterine cancer. So you got to take the progesterones. Now, if you don't have a uterus, then the current guidelines are don't take the progesterone. But I have to say, again, we have very, very little research on that, because, progesterone does some things. I mean, the reason that we say, well, you don't really need it, is that estrogen does most of the stuff. Estrogen does good things for the bone, progesterone a little bit for the bone. Estrogen does good things for the brain, although progesterone does some good things for the brain too. Progesterone tends to be a bit calming, so sometimes it can help the anxiety, that women are going through. But right now, the recommendations are, since we don't have a lot of research, just to take the estrogen alone if you don't have a uterus, but to take both if you have a uterus. But again, I have to say is that there's a lot of people in the more holistic, natural, pathic fields that really think you should take the progesterone as well. So, it's just hard. There's probably actually nothing negative about progesterone. So some women kind of say, well, I think I would like to take it to see if it helps me calm or helps me sleep. But, and that's now that we have natural progesterone. Up until, really not that long ago, until, it really, late 1990s, we only had these synthetic progestins. They're called synthetic progestins. So natural progesterone is what your ovary makes, your body makes, whereas these synthetic drugs are very much different. They're different than our natural progesterone. So when you take them, yes, they help the uterus and they do what they should on the uterus, but they can also do other things. They can affect the testosterone receptors. They can do some other kind of negative things. So that's why we don't like, the synthetic progestins. So we don't like people to take those. But see, we need more research. Maybe it is good for women to take the natural progesterone if they've had it, if they've removed.
when you're talking about like the synthetics versus, is it bioidentical? Is that the like yin yang to that? Okay. So we're talking about like, why would somebody be recommending the synthetics if there are these other ones?
Yeah, they shouldn't.
Okay.
In this day and age, I mean, when natural progesterone, it doesn't get absorbed very good, so they had to really figure out chemically how to make a pill that gets absorbed. And so they call it, if you look on the label, a lot of times they'll say micronized progesterone. Micronized means they've taken the progesterone and made it teeny tiny pieces, so when you swallow it, you'll absorb it. So up until we had that, though, we had to use the synthetic ones because we didn't have a natural one. And when that natural one first came out, it's really, really expensive. In fact, today it's still, there's a generic natural progesterone, which is still kind of expensive, and a lot of insurances don't cover it, which is really frustrating. So, but yeah, we like to avoid the synthetic progesterones. We really shouldn't be using those for HRT. Having said that, all of your birth control pills have the synthetic progestins in it. So we're kind of like, that's one of the reasons why birth control pills, they're more potent. They have synthetic drugs in them. They are a little more dangerous, I should say, than natural bioidentical hormones. I'm not going to say hugely because they're such low dose, but you've probably heard that women on birth control pills, especially women who smoke, may have a little more issues with heart disease and blood clots and things like that. So in general, we kind of, I don't want to dismiss birth control pills, but we don't use birth control pills for hormone replacement therapy.
Okay, that's good to know.
Actually, I'm going to come back and explain that in just a little bit more, but I'll end right there.
Yeah, well, I think that's really interesting because I think, and again, it's just what we've been conditioned to our whole lives. Like it was just kind of like a natural course of action that I got on birth control pills, and I didn't even think twice about it, just in terms of like what I'm putting in my body and the effect it would have because I didn't want to get pregnant.
Right.
But like,
well, that's just, weighing the benefits and risks and which one is the one that you don't want the most, or,
Yeah. In pregnancy, there's risks to pregnancy. There's blood clots, there's bleeding, there's risks to pregnancy too. You kind of look, sides.
Okay, I'm going to jump. We keep saying, sorry, I'm going to, because we're on this, two things came up, and one of them is not at all on our schedule, but you mentioned it. And so I just am like, I'm curious about it because I think this also blew my mind a little bit, was testosterone. Because I like maybe kind of knew in the back of my head, like, oh, we have testosterone in our bodies too. But that's another one now that in our mid 40s, I have friends that are like, oh yeah, I got the little pellets of testosterone in my butt. They like stick these little pellets into your butt cheek. And I was like, what is that? And
what is that? Oh my gosh, I've never heard of it.
What does testosterone then do for our female bodies?
Wow, that's a good question because that comes up all the time. Here's the when you go through menopause, your ovaries shut down and they quit making progesterone and estrogen. The thing with testosterone, and actually, did you know that your estradiol is made from testosterone? Yeah, it is. Yeah, testosterone goes into your ovaries, and then your ovaries makes estradiol out of the testosterone. But testosterone, is made primarily by the adrenal gland. And the adrenal gland slowly winds down as we age. So your testosterone level peaks around age 35, 36. And then it slowly goes down. At the time of menopause, it doesn't suddenly plummet down. So it just slowly goes down, whereas estrogen and progesterone plummet down. So the thing is that when women go through menopause, it's not like, oh, all of a sudden I need more testosterone. No, you're making as much testosterone, as, anybody else your age that's not going through menopause. So it's very controversial whether or not, menopause per se is an indication to take testosterone, right? So, and we need a lot more research on this. And there's actually a lady and professor in Australia who's doing this huge study on testosterone replacement. So it'll be interesting in a few years when we get that. But right now, the experts are saying there's really no reason to take testosterone as a menopause treatment. Like there's no reason to take it at menopause any other time than when you're 40 or 35 or 60, But a lot of women feel that it helps their libido. And if you look at all the studies, that's the only thing you can say it really, really might help is libido, your interest in sex.
I was going to ask because you said it peaks at 35, 36. And I was like, isn't that like when women's sexual, like our libido also peaks?
Yeah, there's a correlation.
Oh my gosh. That's when I got pregnant. Then I kept having babies after that. Oh my gosh, this is so funny. Oh my gosh, this is mind blowing. Actually, I really honestly did not know about the testosterone creating the estrogen. It's just
And so I mean, so people go and they get these pellets put in, and I mean, it's just a way of giving you without taking a pill. I mean, you don't want to take testosterone pills. They're dangerous because they are not metabolized good and they can cause side effects. So you either have to put testosterone in your skin, which there is no female testosterone patch. There's one in Australia, I think, but there's nothing here. Or you can put pellets in, which are none of the there's estrogen pellets, there's progesterone pellets, there's testosterone pellets. None of them are FDA approved. They're you get those through kind of a compounding pharmacy or a doctor who's out there, an entrepreneur, let's put it that way. A lot of money off of pellets. And you put them in and they stay in for 6 months and dissolve. But the menopause decide that experts don't like pellets because you don't know what you're getting. You don't know how much you're getting. Once you put them in, you can't get them out very easily, and if you have a problem. So, but having said that, there's women who take it and then they feel better. But testosterone per se, it can help the bones a little bit, but not as much as estrogen. And there is some negatives on testosterone. Again, we've mentioned that men have more heart disease than women. A lot of that's their testosterone. Testosterone actually may increase belly fat a little bit, then decrease it. So, and then let me just say this because I always love something new. Is I was at a lecture recently on vocal cords and testosterone. This is amazing. Women who had been testosterone after 2 years can get some changes in their vocal cords so that they talk deeper, and then that's irreversible. So that was something negative about testosterone that I hadn't learned.
Yeah. Wow. No thanks.
Yeah. Okay, this is kind of the second part of that question that I wanted to ask is, so we keep saying like when you're on estrogen or when you're taking progesterone. When I talked to you a while ago, I thought it was really interesting because you are quote unquote on these matters. And you just said like testosterone, do not take a pill. It should only be one of these pellets that is like inserted into your butt cheek, if at all, if you're even using it. Wait for the
or skin or on the skin.
And then I remember when I was talking to you about estrogen, you were like, well, and you kind of walked me through like creams, patches. And so can you walk the listeners through that?
Yeah, no, I think that's really, really important because and again, this was one of the issues with the WHI that hasn't been talked about a lot is that back then we used the Premarin. Premarin is an oral estrogen. It's for, Megan probably doesn't know this, pregnant mare's urine, Premarin. Premarin used to be, millions of women were on Premarin. They didn't realize that's where the name came from. Pregnant. I just think. Anyway, so Premarin is an oral pill. And we also have oral bioidentical estradiol. Estradiol is our bioidentical estrogen. The thing about oral pills is that whenever you take a pill orally, it goes into your stomach, and then everything in your stomach goes directly into your liver. And then when stuff goes into your liver is kind of like this computer that changes drugs. It adds things that, does all sorts of things to drugs, and then it spits it out into your system. So when you take an oral pill, oral estrogen, the liver changes it to a certain degree and also then makes some other little products that actually increase blood clots and also actually increase inflammation. So when you take an oral pill, you're actually getting some byproducts that you don't like. That's what increases blood clots, and that's what can increase inflammation. Those things can actually down the line cause problems. And probably in the WHI, that was also contributing to the fact, you have these older women, I'm old, but they were older women who probably already had some blockages. You put them on something that caused blood clots, and then boom, they got a heart attack or a stroke. So a lot of the negatives from oral estrogens can go back and be attributed to the fact that they were oral. Whereas now, over the last 15 years or so, 20 years, we have topical estrogens. We have what they call transdermal. Transdermal means you put them on your skin. And when you put something on your skin, it seeps through the skin and then goes directly into your little capillaries in your blood vessels and then is circulated. So it doesn't take this huge stop at the liver and get messed up. Whenever you can actually take much, much, much lower doses. So these patches that are available, estrogen patches, you get much lower dose. And then they don't actually, the research shows they don't cause blood clots. So oral estrogens, birth control pills, any kind of oral estrogen type drug can cause blood clots, whereas the transdermal doesn't. And, that's available in patches, it's available in sprays, it's available in gels. So,
Yeah, mine's cheaper. I just put
I feel like bypassing the liver in general, right? Shouldn't we just do that with everything? Like, I mean, some things, no, but like any kind of like medications, I feel like if you're,
yeah, I mean, it's kind of a pharmaceutical issue, is that not all drugs can go through the skin easily either. But yeah, you're right. I mean, there's a lot of drugs, that are now, tons of drugs that are transient, but they're more expensive to produce and da. So Megan, that's you're right. We should bypass the liver as much as we can, but it just economically doesn't make sense.
Yeah, I was going to tell people. So I have this tiny little, like less than 1 inch wide, clear sticker.
Yeah.
I put on like down by in my like bikini area, and I swap it out every 3 days. And when I was like first got this, I was like, what? This little sticker is going to make a difference. But within about 2 weeks, I swear, I was like, my anxiety was back. I was like, oh, there she is. Here I am.
that's so
Like, I felt
nice.
normal again.
I know. I mean, the amount of estrogen in your bloodstream, if you get your little report, and it says 20 picograms per nanometer. I mean, a picogram. I mean, you can fit like 10,000 things into a hair, and it still wouldn't even be a picogram. I mean, the amount of estrogen that's actually, it's amazing to me, the amount of estrogen that's in our blood is tiny. So that little patch, is delivering you plenty, but it doesn't seem like it, does it?
No, I still can't believe it. It is what it is. But I like, if I am going on a trip, I'm like, where are my stickers? I got to bring stickers.
Yeah. So can you just explain, what are like, I mean, so what are more symptoms to look for if you're like just starting to go through I mean, I feel like I've already gone through so many, and now I'm getting like nervous that I'm too late to start on my HRT. Which you did mention that sometimes it can be, you want to try to start before, like 10 years before, 5 to 10 years before.
Well, yeah, I'm glad, Megan, I'm glad you brought that up, because this is what's tricky. And, I get this question all the time, and, I talk to it, and I keep trying to figure out how to explain it to people. So once menopause hits, the ovaries are bottomed out, right? So it's like, there's no more estrogen, progesterone. So we just give people low dose HRT, right? The problem is, I wanted to bring this up in perimenopause. Okay. What starts perimenopause? Well, we're born with like 2 million eggs in our ovaries, 2 million eggs. And then this weird process happens over time where they just get slowly eaten up and destroyed. We don't really totally understand. But then at some point, you end up with kind of what we call a critical level of eggs in the ovaries, like about 2,000. So you got from 2 million to 2,000. Once it gets down to 2,000, one of those eggs it's not able, the ovaries are just not able to pop it out and mature it and get it ready. So that the egg kind of sits there a while, and then it comes out, and then your period is late, right? So perimenopause occurs when the eggs in the ovaries are down to such a critical level that you can't ovulate monthly. So you get irregular periods. But sometimes an egg actually might come out on time, or it might be late, or, there's just no predicting, right? So you may have a period, you may not. But the other issue is that around each egg, there's some specialized cells called follicular cells. And those follicular cells are what make our estrogen and our progesterone. So when the egg supply goes down, and then when an egg isn't getting matured to ovulate, then we don't have very many estrogens. So what happens in perimenopause is that the estrogen level will kind of go down, but then it'll kind of go up, and then it'll go down and up and down, and it kind of zigzags down over that 3 or 5 year period. So some months your levels are, they've really dive down, and then it'll kind of go up again, and then they'll dive down. So through perimenopause, your hormones are going like this. So it's not so easy just to take something, right? You can't just throw someone on HRT, because when their levels are up, you're just kind of adding more estrogen, and women kind of get PMSy or breast tenderness. But then you really want to take the estrogen when it goes down. But it's kind of like you got this moving target, and it's really hard to just put people on hormones. So that's what's really hard is, okay, when do you start HRT? If you're having a lot of, if you're up and down like this, it's kind of like, oh, shall I, like you, Erin, I better put my patch on. And then you go, oh, I'm having breast in it. Oh, I better take that off. And then, oh, I'm having hot flash. I better put it back on. So it's really difficult to treat with hormones during the perimenopause. And we just have very little guidelines and very little to offer for women other than one thing, which I'm going to segue into. But once you get lower down, then a lot of times women are having more hot flashes. And then if you're having like a period every 3 or 4 months, then it's a little easier to start HRT and say, okay, let's start it now, and we'll try to coordinate that with bleeding problems. So what we recommend in perimenopause, what the experts recommend is a low dose birth control pill. So after having kind of bashed birth control pills, I'm going to have to say that there probably is a place for it, because with birth control pills, they're much stronger than HRT. They're stronger. And so what they do is they stop your brain from telling your ovaries to make hormones. So basically, when you take HRT, it shuts down your ovaries. So basically, you're getting your hormones from the HRT. So it will stop the irregular up and down on the hormones. It'll stop ovulation. So it'll act as birth control. A lot of women still need birth control right up to menopause. You can get pregnant, months before you go into menopause, believe it or not. So a lot of times we'll use birth control for those 2, 3, 4, 5 years. And then when you hit menopause, then we switch over to HRT. Okay. So yeah, I know that perimenopause is a hard time to treat.
So that makes more sense that my doctor would have prescribed a lower. Yeah.
I know. Well, this one, I was like, your doctor's a quack, Megs.
I know. I was like, what?
Once you hit menopause, though, she'd be a quack.
Right.
Yeah.
Right.
Yeah. But yeah.
You mentioned hot flashes and like that kind of, so fluctuation in period, hot flashes, this kind of like brain fog. I don't remember if it was you or this other, I follow also Dr. Marie Claire Haver.
She's good.
Yeah, I think she's great. And I don't know if it was you or her that said that sometimes like people are like, oh, well, I don't have hot flashes. And I don't remember which one of you said it, but you're like, well, sometimes, the quote unquote hot flash could almost present as like an anxiety attack.
Yeah.
Like it doesn't have to be like this flush of heat, where you're like sweating and can't sometimes that could happen out of the blue just with like anxiety.
Yeah. Yeah. Hot flashes are funny. They call them vasomotor symptoms, because it has the signal from the brain affects our blood vessels. So sometimes you flush, but sometimes some people get palpitations. Some people just get kind of anxiety, a lot of hot flashes. They don't know it. They've done studies where they put sensors on people, and they can measure what the blood vessels are doing. And, they can say, oh, you're having a hot flash. And you go, well, I don't feel a hot flash, but I feel lightheaded, or I feel dizzy. So yeah, a lot of women can have atypical hot flash symptoms for sure.
Okay. So can I ask you a question, personal one? So this is very odd.
Healthcare that I'm providing. Say a hypothetical person.
Yeah, right. So would this be a symptom of perimenopause that I would be going through it? So sometimes at night, not every night, my calf sweat, like my legs, it's really odd. And I was telling my husband, I was like, it's just my calf. So now all he says, just the calf. But so it's kind of funny around here, but it's not when you're sleeping and you wake up and you're like, what is going on? So is like sweating like that in weird places? I've never sweat my calves before.
It probably is. Some women just, it's their head. Some women's their whole bodies, and sometimes it depends on, I don't know, maybe if you wear socks, if you're, it depends on if your legs are warmer, if you have a blanket over your, but yeah, it probably is.
It's probably safe to say that Megan's legs are fully in menopause.
Yes. Yes, totally.
We're starting from the autumn of.
Oh no. Oh my gosh.
Yeah, but I just think there's so many things that so Megan and I are both in our 40s. And we have so many friends, and I have friends, like 10 years younger and 10 years older. But it's like that kind of span in terms of like the weight gain and hot flash or anxiety attacks and the changes like hair growth. Like I'm growing hair now in place. I was like, where did that hair come from? And
Because
that's
remember your estrogen level is going down, but your testosterone is kind of staying. So as women get older and older, they get more testosterone effects than estrogen effects.
That makes sense.
And, I mean, yeah.
I was gonna say like peach fuzz, like my face is like peach fuzzy. No,
That's why everybody's dermaplaning now. All the people, like, they're getting all this hair taken off their face.
That'd be another negative to taking testosterone, right? You can get, women, that is one of the side effects. You get a little more hair growth, oily skin, that sort of stuff.
wow, this has been.
Oh my gosh.
Yeah. Let me go back to the, I wish we had more help for, we need more help for what to do in perimenopause, because it really is a hard time, because, it's just hard to know what to do hormonally. And I've experimented, like saying, okay, well, just put a patch on 10 days a week, or, I mean, it's hard to figure out what to do with women. But, and then as far as one new front on the birth control pills is that there's this new birth control pill that's called Nextellus. Have you heard of that? Nextellus. So birth control pills have two hormones. They have the estrogen and then a progesterone drug. So the estrogen, again, is a synthetic. It's phenylestradiol. It's stronger, and it's not terrible, but it's stronger than HRT estradiol. And then the progesterone, is always a synthetic progesterone. But anyway, there's a new estrogen called estetrol, which is actually a bioidentical estrogen, estetrol, in this one called Nextellus. So I'm kind of excited about that. I think that maybe that would be the best birth control for women that, for perimenopause, but just throwing that out as food for thought.
Okay, thank you. I have one last question before we kind of get into a closing and make sure everybody knows where to find you, Sandy. But so what about, so I run with this like group of like, they're in their late 30s and they're all on IUDs, and they're like, what period, like what hormones, they have no, like, not, they don't, like, there's nothing that they experience. I remember actually starting my period at one of their houses, and I was like, oh, can I borrow a tampon? And they're like, what tip, where? And I was like, house, a woman's house.
Yeah.
But how do IUDs affect peri and then menopause?
That's a good question. There's a bunch of different kind of IUDs. There's some that don't have hormones and some that have hormones. And it kind of depends on what kind of, period, what you have. A lot of them, the one, if they're not having periods, they probably have a hormone in them, like a progesterone hormone.
I think they're all on Mirena.
Yeah. And there's Mirena and Skylar and I forget all the names, but yeah, they have hormone in them, and it's a very low dose of a synthetic progesterone, and so it actually kind of keeps the uterus from building up. So they still are having their ovaries are working fine. It has nothing to do. They're still doing all their ovary stuff, so they'll go into perimenopause just like normal. It's just that they won't have the bleeding issues. And in fact, it's a good point, because some women, as they go through perimenopause, are having a lot of bleeding problems and up and down problems, the doctor will say, hey, let's just put in a Mirena. That'll help the birth control issue. That will provide you birth control. That will keep the uterus from bleeding. And then you can take hormones, estrogen on top of that. That's actually kind of a perfect solution. Problem is that's not FDA approved. And so some doctors will go, well, we're not really supposed to put this in. Doctors are reluctant to do it, but that is one option that can help people, especially. Supposedly, the Mirena is only for, it's not for HRT use. It's only for heavy bleeding or birth control. So, if your doctor will kind of put in the chart that that you need it for that.
Yeah. And then, well, you mentioned this too, but what about insurance? Because you said sometimes insurance doesn't cover progesterone.
Yeah, it's really frustrating because, let me just backtrack and make sure we're not misleading any of your listeners. Is that right now, hormones are only indicated. I mean, we're still in the UHI policies, I'm afraid to say. And so insurances go by what the policies are, and that hormones are only to be used for severe menopause symptoms, at low doses for short periods of time. That's kind of where we are. So a lot of insurance goes, well, you're not supposed to be on them anyway. So they frequently will just not pay full price or put them in a tier 3 for ridiculous reasons. So, a lot of women are frustrated. They can't, the patches are more expensive than the pills, unfortunately, and the progesterone can be expensive. Hopefully I know the Menopause Society is trying to get insurances to pay. And of course, Medicare you're not supposed to be on them at age 65 anyway. So Medicare, tends not to pay for them.
So, but if you go to your doctor, like, and you present with the symptoms that we've all talked about today, like that would most likely be in the tier that would be covered.
It should. Yeah. They're getting better. It just depends on your insurance.
Okay, Dr. Sandy, we're like way past time, but holy, like
so good.
mind blowing. Yes.
Yeah.
So where do people find, okay, so first of all, like again, like if you haven't bought the book, buy the book. It's called The Estrogen Question. It's on Amazon. It just like, it's this podcast on steroids. No hormone intended.
Yeah.
It's this podcast on estrogen.
Cream steroids. Yeah.
Yes. So, but any, like, if are you available for consults or like anything else that in terms of how people can get in touch with you?
I mean, I'm retired and I'm not, doing any kind of clinical. I just like to share my knowledge and try to educate people. But I do have a website, yourestrogenquestions.com. And, I always answer questions on my website. So, I haven't been super active. I go up and down, as far as I get frustrated that, that things aren't changing, and then I get reinvigorated. So, but this rate, I'm going to, I can put more stuff on my website now, but I do respond.
Okay, cool. And we'll link all that in our show notes so people can access it really easy. And then the last question I'll just kind of, it wasn't on our schedule, but you've mentioned it in some of the talks that I've had with you, is the Menopause Cafe.
Oh, yeah. That's cool. Yeah. A few years ago, I started working with a wonderful woman, Nathalie Bonafé, Bonafe. She's from France, and she started a online Zoom menopause cafe, which is something that they do in Europe a lot. They actually meet at a cafe and chit chat and talk about menopause, and so she started an online one here, and it's you can register through Eventbrite, and it's the 15th of every month on Zoom. It's
fun.
Is
great.
Yeah, we have people from all over, and it's just not. I'm there just as kind of a consult, not a consult, but just to make sure that some people say some weird stuff, and I say, I think that's very good to do, but it's just people sharing and talking and learning about their menopause journey. Yeah.
That's awesome. We will
amazing
show notes too, so people.
That'd be great. Yeah.
We should do a perimenopausal cafe and talking about, oh my God, I'm crazy. No, you're not. You're not crazy.
Yeah, you just have your estrogen is like slowly fading. Okay, well, thank you again and again. And I would just encourage
you, Sandy.
You're welcome. Nice to meet you, Megan. And
nice to meet you too.
Spread the word, ladies.